Heart diseases in pregnancy. Heart diseases in pregnant women. Now, if we are aware of the physiological changes in cardiovascular system in pregnancy, only then we will be able to identify the pathological changes. Now, pathological symptoms that we can see in heart diseases in pregnancy. If there is progressive dyspnea with worsening NYHA grading, if there is paroxysmal nocturnal dyspnea, if there is orthopnea, hemoptysis or chest pain. These are the pathological symptoms, and if patient presents with these, we should suspect any heart disease in the pregnancy. They are progressive dyspnea, paroxysmal nocturnal dyspnea, orthopnea, hemoptysis and chest pain. Now, what are the pathological signs of heart disease in pregnancy? It is cyanosis, clubbing, systolic murmur more than grade 2, diastolic murmur. It is physiological only in 20%. Wide split S2, loud P2, any evidence of arrhythmia or heart failure, or persistently distended neck veins. Now, how will we diagnose? First investigation is echo. This will tell us about type of abnormality. The most common heart disease in pregnant women is mitral stenosis. Most common congenital heart disease in pregnant women is atrial septal defect. Most common congenital valvular heart disease in pregnant women is mitral valve prolapse. Now, according to the type of abnormality. Type of abnormality. Heart diseases that are well tolerated in pregnancy are usually congenital lesion. Examples are mitral valve prolapse, repaired ventricular septal defect, repaired atrial septal defect, corrected tetralogy of Fallot, and patent ductus arteriosus. Heart diseases that have high maternal mortality. The mortality rate can be up to 50%. The examples are Marfan syndrome with involvement of aortic root, dilation more than 45 mm, coarctation of aorta with involvement of aortic valve, ascending aorta dilation. If there is pulmonary hypertension in Eisenmenger syndrome. These diseases present to us in early pregnancy, and since they have high mortality rate, we should advise medical termination of pregnancy. Other heart diseases in which we advise MTP is in severe mitral stenosis when the valve area is less than 2 cm square, severe aortic stenosis when the aortic valve area is less than 1.5 cm square, if ejection fraction is less than 30% and NYHA grading is 3 or 4. Now, the heart disease that is most commonly associated with mortality is mitral stenosis. And if pregnant female dies because of mitral stenosis, it is known as indirect maternal death. Preeclampsia will be a cause of direct maternal death. Now, a patient of severe mitral stenosis, if they come to us prior to pregnancy, we advise them valve replacement surgery. If the patient comes to us during pregnancy, we advise MTP. But if she wants to continue the pregnancy, we can do balloon valvotomy. Ideal time is second trimester after 20 weeks. The valve replacement surgery is not done during pregnancy as it has high mortality rate, around 30%. Now, if a patient of mitral stenosis has undergone valve replacement with mechanical valves, they need lifelong anticoagulation. If there is bioprosthetic valves used, they don't need anticoagulation. Bioprosthetic valves need to be replaced every 10 years though. Now, if a patient with mechanical valves get pregnant, we give them anticoagulants. If a patient with mechanical valves get pregnant, we give them anticoagulants. In the first trimester, the management depends upon the dose of warfarin. If more than 5 mg per day is the dose, we need to switch over to heparin. For 6 to 12 weeks, we give them low molecular weight heparin because during 6 to 12 weeks, warfarin has highest teratogenic effect, causing chondrodysplasia punctata. If the dose is less than 5 mg per day, we can either continue warfarin or switch over to low molecular weight heparin. At 12 weeks, we will again switch over from LMWH to warfarin. For 12 to 36 weeks, we will give warfarin therapy. At 36 weeks, we will switch over from warfarin to LMWH. At 36 weeks till onset of labor, we will give them LMWH because it doesn't cross placenta. Warfarin crosses placenta and fetus has therapeutic levels of warfarin. So the baby can have bleeding at labor if on warfarin. Now a scenario, if patient was on warfarin and goes into labor at 36 weeks, then we will do C-section. No vaginal delivery should be attempted because of risk of bleeding. Now, what will be the mode of delivery in patient with heart disease? Preferred is vaginal delivery. C-section is reserved for obstetric indication that are placenta previa, contracted pelvis, etc. Spontaneous onset of labor is preferred over induction of labor. Induction of labor is not contraindicated but not preferred. Pain relief is essential. Preferred method is epidural analgesia because pain can cause cardiac decompensation due to tachycardia. Now, which heart diseases are indications for C-section? Marfan's with aortic root involvement, coarctation of aorta with aortic valve involvement, severe aortic stenosis or aortic regurgitation, aortic dissection, patient on warfarin and goes in labor, and patient is a case of refractory heart failure. In all these cases, ejection fraction is low, so general anesthesia is given. Spinal or epidural anesthesia causes hypotension and it shouldn't be given to patient with anticoagulant therapy. Now, if we are doing C-section in female with heart disease for obstetric indication, anesthesia will be epidural and less commonly we give neuraxial also. Now, if patient has these indications from 1 to 6, we were giving general anesthesia only, discussed previously. Now we should keep female in left lateral position and keep oxygen ready. We should restrict IV fluids at around 75 ml per hour. We should restrict the number of per vaginal examinations. At the time of membrane rupture, we should give her prophylactic antibiotics, ampicillin plus gentamicin. We should cut short second stage of labor by doing instrumental delivery. Forceps preferred over vacuum. Now the risk of heart failure is highest in the immediate postpartum phase, then in the second stage of labor, then after 32 weeks. Now prevention of heart failure is done by giving injection Lasix after delivery and hanging the legs from table. These two methods reduce venous return. Now patient is a case of PPH with heart disease, so drug of choice is oxytocin. Which drug will not be given is methergine. Methergine causes severe transient hypertension, so it is contraindicated in heart disease. Now in pregnancy, according to American Heart Association, we give anticoagulation plus aspirin. According to European Society, we only give anticoagulants, and this is the more recent guidelines. Now female with bioprosthetic valves don't need anticoagulation We should only give aspirin during pregnancy, also low dose. Thank you.